Welcome to College Bound Success, College to Career, the podcast for college curious and college bound students and families. Together, we'll navigate the journey from high school to higher education and beyond. I'm Mark Mostalski, an independent college success consultant. I'm here to share strategies and insights and stories to help you make confident choices about college, careers, and your future. So without any delay, let's get started. Today, I'm super excited to be joined by my guest, Dr. Sharon Giarrizzo-Wilson. Dr. GW, as she's known to many people. We had the chance, I got to meet Dr. GW and work with her closely when I was at the University of Colorado's College of Nursing. Dr. GW, thanks for joining me.
Oh, very happy to be here. Thanks for asking me to join, Mark.
Yeah, no, I'm looking forward to it. I think, when I started thinking about putting together a series about healthcare and in particular nursing, I actually chatted with Mike Billar, who works for Arizona College of Nursing. He's actually running a new campus that they have down in Texas. But I wanted to bring you on board because I know that you have a great, robust, and rich history in the industry. But can we just start? Can you share a little bit about your background so we know who you are and what you've done and what you do?
Okay, my background. Well, it's interesting for sure. So, as you know, I'm faculty, and I am the specialty director for healthcare informatics at the University of Colorado College of Nursing. I tell my students all the time that are in this information technology specialty in nursing, which is the integration of health technology into healthcare, patient care. When I started in nursing, we didn't have computers in hospitals. We didn't have smartphones. Our phones were bolted to the wall. We didn't have
what? You didn't have one of these?
No, I didn't have one of those. Eventually, I had a couple of those early technologies, but we also didn't have anything that was automated for documentation. So I graduated in 1979. Now that tells you I've been around the block for a few times, and I graduated from a diploma school of nursing. Mm. Most of those organizations are no longer in existence, though. Hospital Corporation of America, HCA, they do have a new program that replicates some of the diploma program sequence. So the diploma program was 3 years, and you graduated, and if you wanted to get your bachelor's or go on for education, you had to, most places required you to repeat all the courses you had already taken. Mm. I ended up starting one of those programs and said, this is not fun. And then I relocated to New Hampshire, and I was working there. So I originally started in coronary care. And coronary care back then, we just had a little monitor that was up on a shelf that took an EKG. See what the patient's heart's doing. And from there, I went into the OR and never left because the patient-clinician ratio was perfect. You couldn't do surgery without a doc. You couldn't do surgery if you didn't have an anesthesiologist or a nurse in the room. And yes, we had a nursing shortage back then too. I think we always have a nursing shortage. But in the OR, we had a number of different technologies. They used to do open heart surgery. And back then, they used to split the chest and they would put the person on what they call the bypass. So the blood would circulate into this massive machine that was to the side of the surgical table and then back into the patient while the doc was repairing the heart. That was considered innovation. Yeah. We had microscopes that were very, very large. direct vision, no digital application to it. It was like what you saw in the magnification was what you were working with. Now the technologies are all automated. A lot of them have AI embedded in them because it produces real-time data information back to the operating surgeon. Robotics weren't in existence back then in surgery. What we had was a telescope that we might look into somebody's abdomen without making a big incision. And it was projected on a little TV, but bells and whistles have changed. And importantly, for your audience, they need to know that when I started, everything that I used in surgery and nursing was considered high class technology. Mm-hmm. And now I've seen all of that technology become matured, where we have these digital applications. And we're currently in a time of having digital health. If you read some of the news articles and what the federal government's talking about or what healthcare is doing, they talk about digital health. And that's because we have those smartphones, we have those wearables, like the Fitbits or your smartwatches. There's even technologies that are embedded in athletic shoes that can measure all the enzymes that are being excreted by the patient while they're running or exercising, and in your clothes, how much solar exposure you're getting. They even have a pacifier now that will analyze an infant's saliva and determine the number of nutrients and enzymes that are in the saliva. And these poor little kids that are struggling to survive, they don't have to go for some of the invasive procedures we do. Right. They just suck on a pacifier. I think that's so cool.
That is cool. I never even thought about that. Let's see, if Apple created it, would be the eye pacifier.
Oh, bad. It's probably coming. They even have these bandages. So all nurses and doctors put bandages on patients. And about 2 years ago, 2 different groups of researchers were working on this nanotechnology. One bandage, nanotechnology, could identify the level of wound healing before the human eye.
Wow.
And the other one could identify an infection before the human eye or the nose, because a lot of times you can smell infection in a wound. And those 2 products are starting to come out now. And it's a game changer for individuals who have chronic wounds that won't heal, or wounds that are starting to cause the patient problems. So I'm thinking infections, or there might be some other issue with the tissues that are going on.
Yeah.
So the technology in healthcare is really cool. And what that means is I've lived through all of that. From the time of paper to the time of what we're really starting to innovate. And now we're at a point where we've got AI. Everybody's talking about AI. And I laugh because we've had AI since the 1950s.
Sure.
When I tell students that, they go, huh? And I said, oh, yeah. AI was envisioned in the early 50s before we had computers that could accommodate it. And the computers back then were the size of a 10 by 10 room, filled with this giant piece of technology that could add, subtract, multiply, and divide. That was it. It didn't do anything else. And we thought it was the best thing since sliced bread, let me tell you. And we have been using AI in healthcare since the late 60s, early 70s. People have heard of natural language processing or machine learning. Those are the 2 most common terms. And they are actually forms of AI, where the technology gets the data, it processes it, it generates an output, and it makes a recommendation. That's a type of AI that is pretty standard. What we're seeing now, generative AI, is a tool that mimics human intelligence. It was trained on the internet, and I won't go into that. But the technology is progressing so quickly. It is now refined, and it's getting some guardrails, which I'm really happy about, especially in healthcare, because the technology is programmed to generate a response, where the other one would generate a response on what it had. If this technology in generative AI doesn't have an answer, it will create an answer for you. And if you've heard about the confusion or the misinformation that might come out from generative AI, that's because the way the model works. And now we're getting it to the point where it's being trained on, not on the internet, but on scientific information, healthcare information, so that it can generate and create recommendations and identify deviations in patient care based on the information that it's getting that's specific to patient care, which is really cool. And I encourage everybody to pay attention to that. I approach this type of AI with some hesitancy, because you need those guardrails. And if you don't have the guardrails, that's where potential patient harm can happen. And our electronic health record vendors are realizing that, and they're becoming much more savvy in how they create their model. Okay.
Yeah.
Now so I got into that.
Yeah. Well, if you could, you mentioned this incredible, you've seen this evolution of technology to where we are today. To like you said, like bandages that basically are collecting and learning, pacifiers. So could you help explain, all of these things are taking in data, and the data is collected, but then somebody has to do something with that data. Otherwise, why collect the data, right? So I think, is that where healthcare informatics comes in? Like, what should the everyday person, how should we think about that?
So informatics, the term informatics is technology and data generation. And our IT colleagues, they're part of that informatics group. Our EHR, electronic health, and electronic medical record vendors, they're a part of that.
Like Epic. A lot of people are probably familiar with Epic or Cerner.
Right. And even the developers of the technologies are part of the informatics space. But healthcare informatics and nursing informatics and medical informatics are focused on that specific specialty of practice and what it looks at. So healthcare informatics is broader than nursing informatics, and it overlaps very, very closely, because at CU, at College of the University of Colorado, we only accept nurses into our master's program.
Right. You have to have at least a bachelor's in nursing.
Right. And people ask me all the time, why healthcare? And I says, well, it's because informatics it's essentially a team sport. You don't do this in a silo. You have to work with developers. You have to work with multiple different specialties in healthcare. And you have to work with the technologies, the various technologies, in order to bring that data from the technology to the point of care where the clinician can use it, where the healthcare provider can use it to interpret and then make the recommendations for that unique individual. And that's really, really critical. To have data, that's great. But like you said, you have to do something with it. Well, it has to be usable. So, it's one thing getting a database. So, um, if you think of a closet with a whole bunch of clothes in it, it's great to have a closet full of clothes. But if you don't use the clothes, it's kind of useless. And same thing with
Right.
data. You need to have data that is not only usable, but has to be actionable. So what is it within the data? And that's where the human comes in. The technology can make a recommendation. The technology can identify a disease process, but you as the healthcare provider need to interpret it for the individual, for the situation that you're encountering. Is it accurate? Is it correct? Do the numbers match the patient that you're looking at? And that is a problem. I've worked with some healthcare providers who wanted to discharge somebody, but they didn't look at the patient. They looked at the numbers in the patient record and said, oh, everything's good. This person can go. No, you can't do that. You looked at the person. The person did not reflect the numbers. The numbers were like 24 hours old, and patients can change in 24 hours. So the lesson here is your data is only one piece of the puzzle. And it helps to complete the entire picture of the patient experience.
Right.
So in the technologies that we have now, we can bring in different types of data for the information we need to make those decisions.
Right. Right. Could you speak to, you gave a little bit of your history that you started in Buffalo, you went to like a nursing diploma program there, but then you've advanced, right? You did a bachelor's and a master's at Northeastern and ultimately a PhD at Loyola University of Chicago. When did you start making, because you were in the OR and doing that kind of work, when did you decide this informatics approach, I want to become an expert in this? Was there a moment like that just kind of clicked for you, like this is what I want to do? Or was it a mentor, maybe that said to you, hey, I think you should think about this? How did that happen?
Well, I talked a little bit about the evolution of the technology, and when you come into practice first, you finish your schooling, you start working with patients, you feel overwhelmed, and then you start feeling comfortable in your practice. I had always been an individual who was curious. I still am curious, and I encourage people to maintain that curiosity because that's where innovation, that's where creativity occurs. But I would ask a lot of the why questions. When I went into the OR, I had a number of years there. And then when I moved from Buffalo to New Hampshire, I became an assistant director of the OR. And it was during that period of time where I decided I wanted to go back to school. I had already started taking some courses back in New York State that made me repeat everything that I had learned in nursing school. And I said, no, that wasn't for me. But there was a nurse who was going to Northeastern University. She was in the education department. And Northeastern University, in their master's program at the time in nursing administration, long before we called it nursing leadership, we used to have administrators. They included the early concepts of informatics. And when I decided to go to Northeastern, because I had had this long conversation with this individual who was going to school there, I decided that's what I would do. Now, the organization I was at, because I was an assistant director, would not support me as an MP. So I went into nursing administration and got the early concepts of informatics. And when I say early concepts, one of the professors came in with this giant CD disc. I mean, it was huge. It was massive. It's what they used to use in the early 60s. And then the other professor came in with this giant cable and she goes, "This is where we started." And I'm like, "Oh, please spare me." Because at that point we were just starting to get personal computers. I mean, my first computer was a 360, and it was a beast. You had to have a big table in order to put it on there. And then I got really excited when I upgraded to a 486 because it had, it had its own little table, built-in table. And that's what I finished my master's on.
Oh, wow. Yeah.
Before we had Microsoft Office, we had Microsoft Works. Yeah, even the programs progress. But being in the OR, you had so much technology. You don't become afraid of the technology. If you're in a specialty unit, so the OR, the ICU, the ED, any critical care environment, there's so much technology. You learn to troubleshoot, you learn to question why it's working, not working, how to make it better, to pick up whatever data is needed on the patient. So when I was at Northeastern and they had the informatics principles in there, it just kind of fit with everything that I was already doing in the OR. And I remember people wanted to know, and the internet had just come out. Okay, yeah, I've seen it all. And people would say, "How do you use the internet?" And I said, "Well, you want to make sure you're on a good site and you're not going down some rabbit hole someplace else," which back then we used to go into a lot of rabbit holes with the internet because it was so new.
Oh, they're still there.
I know they're still there. I try real hard not to do that. But I would teach people, like my colleagues, okay, this is how you look at an internet site, and I took in high school, I took office administration. So you learn to type. So I was pretty fluent on a keyboard. It didn't bother me. I didn't have to look at it and peck at it. I could just type on it, which helped me. And I would show people what they needed to use, for the keyboard and that. And that was like really rudimentary stuff. But people really appreciated it. And then I went into another organization and I became an OR educator. And I would take what I learned about informatics then and integrate it into all of the programming that I was creating for the staff. So early computers, we had a very early education module that was embedded in the hospital computer, and they were pretty basic then. I mean, computers didn't talk to one another then. And, I looked at it, how the user needed to use the information they were looking at on the screen and how to make those education modules meaningful so that they could take it and use it in practice. So that was the early exposure to informatics. And as my career moved along, I moved from New Hampshire, where I had been the assistant director and the OR educator, to Colorado to work at AORN, the Association of Perioperative Registered Nurses. By that point, I had already had about 28 years in the OR. And I was hired at AORN to be one of their perioperative nurse specialists to write their practice standards. Because of my informatics background, I also got to work with their nursing terminology. So healthcare has a number of computer languages or terminologies that are used with computers to help generate and collect the data, not only of that specialty, but of the patient population you're working with. So I worked on that. And from there, that got me more into the informatics space. I learned more about the terminology. How does that work in a computer? And I got to work with vendors because they were taking the terminology and putting it in
Right.
systems. I also got to work with some of the federal players on because our um, healthcare practice standards are adopted at the federal level for certain regulations, and some of our content at the Association of Perioperative Registered Nurses was being used for regulation at that time, like infection prevention. So we had standards that we contributed to, and I met some of the federal players at that point. And then I was recruited from there to work at the federal level on a federal contract for a group out in Oklahoma on creating the national quality measures for hospital quality reporting for computers. So that was, we learned, let me put it this way, we learned a lot because computers are very linear.
Right.
And we are healthcare clinicians and providers. And, you know, we don't think that way. We have, okay, we're talking to the patient here, and down here we might document a point. And then up here we're talking or looking at the data, and down here we're documenting a point. And to translate that into an electronic measure, yeah, it had some challenges. And what I learned there was early career informatics folks coming out of medicine, they would finish their training and then go directly into informatics. So they had limited experience. I was leading a team of nurses with a lot of years of clinical experience, but had moved into the informatics space. They had grown up in this evolution of technology because we didn't have programs back then. And we were collaborating with the physicians and the federal regulators on how these measures had to work in an electronic health record in order to collect the right data that represented the patient experience. And that was really interesting. You learn a lot about the government. You learn a lot about the perspectives of the people who are working at that level and how they think. But you need to have this other group of people that bring in the real experience.
Right.
Yeah. And from there, I went back into the OR for a while because our contract had ended. And when you're on a federal contract, depending on the organization where you work with, your job kind of evaporates when the contract goes. And that's exactly what happened. And by that point, I was in my PhD program.
Yeah. Yeah.
Because it had been on my bucket list for my master's program. I always wanted to get a PhD because I really enjoyed the research process. And students going into nursing, they need to know there's not only the Doctor of Philosophy, which is a PhD, there is DNP, the Doctor of Nursing Practice.
Right.
P is the equivalent of the MD, so the terminal degree for nursing in the clinical environment, and then the PhD is research focused. So
yeah, thanks for highlighting that there are two different terminal degrees. And I know certainly not being a nurse, but it was one of the most common questions that I received. What I'd hear from people all the time about DNP was like, oh, I'm not interested in doing research. It's like, no, that's not what a DNP is. Research is PhD. DNP is definitely more practice, focused. So with that, I mean, I know you're the specialty director of the healthcare informatics program at CU Nursing. That program offers a master's as well as a postgraduate certificate. It does not offer a DNP, correct? You don't have a DNP?
We don't have a track that goes directly into the DNP, but students from the master's who want a DNP or a PhD have the ability to move into either direction. I've had a few students go from the master's into the DMP because they want to stay clinical. Or they're directors and they want that doctoral degree to help influence the leadership that they're doing. So they get a DMP in the iLead program, the leadership program, but they focus electives on the informatics space. So a project that impacts, from an informatics perspective, that impacts either a population or a whole hospital system, but from a leadership perspective. And if they go to a PhD, they're looking more at the research around to generate new information, new knowledge and practice. And it could be specifically on, well, we'll pick something new. It might be an app, or how the healthcare consumer or the providers interact with a particular app. So generative AI, how is interacting with that? Does it change their perspective? Does it change their critical thinking? Does it enhance their practice by being more accurate in the interventions that they are making for these patients?
Yeah. So in addition, I believe you do teach undergraduates as well. Is that correct?
I
so
do.
Knowing that, if you were talking to somebody, a young adult who's thinking about nursing or knows they want to go into nursing, they're in, maybe they're doing their prereqs, right? I'm in chemistry right now, and I'm taking biology. What would you say to those students about, like, what should they be developing skill wise to be successful in a technology driven kind of healthcare environment? Because that's what they're going into.
Well, I mentioned before, I was curious, and I tell students on a regular basis, be curious, ask the questions, ask the why. If they're hard questions, there's nothing wrong with that. If you need clarification, there's nothing wrong with that. Ask those questions. That's the first piece. And then don't be afraid of the technology. So at the master's level, I've gotten some students that, we've integrated some AI into our courses, and one of them is creating an outline using ChatGPT. And I get students who are so afraid to do that. And I said, it's okay. You're learning. It's like learning a smartphone, pain in the rear. Those smartphones, when you get a new one, have to reset it up. I'm not a fan of that. Okay. But being able to go in and experiment, but also knowing what is the right way to use a tool, a right way to consider integrating it into not only practice in your nursing career or your nursing program, but personal life, like the apps that you have on your phone. Think about, is this app going to give me the information or the tool I need to solve this situation? Does it promote doom scrolling? Don't want that. Does it take me away from interacting with people? And that's another thing. Nursing is very hands-on. Even in the informatics space, like, we are not direct patient care providers, but we need to know what's happening at that level. Sometimes we go out and we talk to the clinicians and the doctors and nurse practitioners. Sometimes we talk to the patients, and consumer health, consumer generated data. So those medical apps that you have on your smartphone or your smartwatch, that data can come into your record in the hospital or your record in the physician's office, so that they can keep an eye on what's going on. So, for example, if you have diabetes, There are apps out there that can monitor and share that data to your doctor. And either the doctor or the nurse practitioner or the diabetic nurse can look at it, and they can call you and say, so how are you feeling? What's your blood sugar? When's the last time you did X, Y, or Z? So that approach to healthcare is going to continue to evolve. And that's something that folks that are coming into a nursing program really need to consider, because you're not going to be in a hospital all the time. You might be you might be an individual who's working with unhoused people, the homeless folks that are out in a community. And about 99% of those people have a cell phone, and it's used for emergency services only. So they don't have to pay very much for the technologies, or it comes free because it's connected with a clinic. And you might be the individual that's asking them, so are you able to access these services through the phone? What is your challenge? So helping to solve the solutions that are needed for the point of care user.
Yeah.
So a lot of this is really, nursing schools are starting to integrate the technologies because we've had some changes in the accreditation process and what needs to happen. But for students who are looking at schools, really talk to the staff that know about the program. You might need to talk to an instructor to find out, so what are you doing with the technologies? How am I going to know that I'm going to have the skill, not just the knowledge, but the skill to use the technologies when I come out? Do they have a simulation center? Do they provide community outreach? Those type of things that really help to embed you into the practice environment before you get there when you graduate.
So you mentioned, that leads me to my question for you is about, you mentioned that a person in this role is not, quote unquote, a direct care provider. I think a lot of RNs out there, when they maybe go to a mentor or they're in in work, they see FNPs, right? And PEDS NPs and so forth. They may not see the informatics, person. And can you make the case, why should somebody, what should they look for to go this route as opposed to becoming an advanced practice RN?
So first of all, you have to think about where you might feel most comfortable. Some people are not comfortable working in an advanced practice NP, nurse practitioner role, because it's more one-on-one. There's a lot of diagnoses that need to be considered. There's a lot of follow-up that has to happen. And that's not a bad thing, but not everybody excels in that area. So there's other routes. You could go into leadership, and then you could go into informatics. And the reason I say that is because informatics, you're not working with just one person anymore. You're working with hundreds and sometimes thousands of people. So some of the students that have come into our program, the master's program, they do health system projects that not only touch thousands of staff in a hospital, and that includes the clinicians and the physicians and the nurse practitioners, but also the patients. So they could touch hundreds of thousands of people with the work that they're doing. And to consider going into this route, somebody just asked me the other day, do we require students that are coming in to have a year's experience? I said, no, but they need to have a really good foundation in practice. So that means study hard in your undergraduate, engage as much as possible. And what I do encourage folks that want to move directly into the informatics, work on the floor or work in a clinic while you're in your master's program. That gives you additional experience as a hands-on clinician so that you're learning all the nuances that you might need to rely on when you're doing an informatics project. So, for example, you might be looking at a workflow, a clinical workflow. So how the nurse does something, say medication administration, how they get an alert, what medications do they need, how they retrieve the medication, how it's prepared, how it's distributed, how it's documented. And if you don't understand that process, it's really hard to improve a solution or to integrate a new technology in there. And I say that because I've had a lot of conversations with electronic health record vendors. And I say, so tell me a little bit about who develops this particular module. And peri-op or OR is my background. So it usually focuses on that. And you go, oh, we've got a medical doc. And I'm like, oh, really? And they're building nursing documentation platforms. And they go, yeah. And then we have a medical nurse who take a look at it. And I said, no, that doesn't work. And they tell me, well, we can't get all the expertise we need. So this goes across the gamut of electronic healthcare providers and developers. So the health technology developers that might be a scanning system for medication or a new application for IV pumps, whatever it might be. If they don't have the right people, they try to get the specialist that's as close as possible, but they don't have, that specialist does not have the appreciation for clinical practice. So working while you're in your master's program or working while you're getting a certificate, even if you've gone to school and you've become an MP and you decide, oh, I really enjoyed that informatics class. I think I'm going to get a certificate. And it's like, continue to work because your specialty, your level of practice brings in new information and knowledge that can really influence how the technologies are used. And as a new graduate, don't think that your voice does not count. Your voice counts.
Yeah.
And you need to speak up. If there is something that is not working right with the technology, find your informatics person, talk to your supervisor, talk to the informatics person that works with your department and say, this is a real problem. We create these workarounds. And workarounds work when you can't get anybody, but it shouldn't be the norm. A system is supposed to work in a sequential process to make sure that it's collecting the data correctly, it's identifying the expenses correctly. And if you're in the OR, yes, you have to attach expenses to your documentation. I'm sorry. It's just the nature of the beast. But when you're in a critical situation, you don't want to have to do a workaround. You want it to work correctly. And we're now using more ambient AI, so voice activated AI.
Okay.
Learn how to use that system, meaning if you go in to see a patient, talk out loud how you're assessing a patient. You might introduce yourself to the patient and say, oh, how is your vision today? Are you having any problems with your hearing? Can you stick your tongue out for me and say, do all these things when you do a head to toe assessment, but keep talking about
Hmm.
what you're doing. That does a couple of things. That allows the ambient AI to pick up the information to create the note that you don't have to put into the record. You just have to review it, make sure it's accurate. But it also helps the patient become more involved in their care and let
Hmm.
them ask questions, and they aren't intimidated to find out more about what's going on with their medical care.
Yeah. I will just, and I always enjoy talking with you, Dr. GW. I know we've done a lot of webinars together, and I just always learn. I mean, today, learning more about you and the work that you've done, I just really appreciate this. I'll just give a personal example. I just literally last week had, established care with a new doctor because my wife and I recently moved. And this type of AI that you were talking about, like when he sat down and was engaging with me, asking me questions, his focus was more on the computer because as I was responding, what was he doing? He was
It was
typing,
being,
right. He was making the medical notes into the electronic medical system rather than turning, right, and having a conversation with, right, the eye to eye contact. So that's just a great example of how a person can feel. It has nothing to do with the background of the doctor or the nurse or what other healthcare professional it is. It's just the relational piece when you're in a small room together and you're talking about something pretty vulnerable like our healthcare.
no, you're absolutely right. And
Yeah.
the technology now, the ambient AI is still new.
Mhm.
And this, they call it care out loud, this talking through the assessment or the interaction with the individual. Um, and it's something that may or may not be taught in the school. But as a new student, you can say, I've heard about this. What do you think? Should we
Yeah.
be practicing this also?
Right.
And that's important too. So students also have a voice in their education.
Yeah.
And I mentioned don't be afraid to ask, but don't be afraid to question
Yeah.
and to make recommendations, because you're going to be doing a lot of reading, not only with the literature or the textbooks that you need to study from. You're going to start reading newspapers. If you're interested in the health technology, you might tune into some of the literature that comes out on it or the nursing recommendations. The American Nursing Association, they
Mhm.
have a lot of information on health technologies and practice standards. Keep an eye on that.
Yeah.
It will help to inform you
Yeah.
where your practice will be going. And it is Mark, not just students that are coming in from high school into nursing programs. We have a number of students who are getting a second career
Yep.
degree.
Later in life, transitioning adults for
And
sure.
I've seen more and more students in their early 20s going from
Mhm.
one degree into informatics. And they see it as a compliment on what they're doing, but then they're
Right.
also becoming a nurse and using the technologies a little
Yeah.
bit more. And as a nurse, you can reinvent yourself over and
Yeah.
over and over. And but the basics always stay the same.
Mhm.
You might go from direct patient care med surge to the OR, like I did, or coronary care to the med surge. You might go from wound care into psychology. I mean, it's amazing what you can do.
Right. So many routes. So
I
so with that, to help wrap us up, maybe somebody listened to this and they're like, I want to learn more. How could they connect with you and learn more
oh,
about the program?
they can reach right out to the university. I get people that I do not engage with or other people engage with. They send me emails on a regular basis going, can I learn more about your program? And the important thing that I do is I make sure that the students are in the right program. I don't encourage students to just apply to my program, and because there's a bunch of different types of informatics programs. Some are more focused on data analytics. Now there's some that are really focused just on AI, but I'm under the perspective and opinion that you need a good solid foundation of what informatics is in order to go off in any direction that you want. Kind of like your basic nursing when you're a new graduate. You get a solid foundation, but you can, you can go into med surg, or you can go into an ICU if they'll take you, an OR, an ED, wound care, pediatrics, maternal. It's the same thing with informatics. You can focus in one area that might be quality measures. You might do another one where it's strictly hospital innovation. You might do another where you're working with EHR vendors or a startup company, which I've done too, which was pretty cool. Your career can be reinvented. Yeah. And when you have that healthcare background, the informatics piece is a tool. Right. It's like another resource that you have in your nursing specialty that can help launch you in another direction. Yeah. Awesome. Well, what I will do is in the show notes, I'm going to put a link to your program, to the healthcare informatics at the University of Colorado's College of Nursing. So people can refer to that and go learn more about it. And thanks for your time. So in wrapping up, I always ask a common question. What is one piece of advice you received from a mentor or a coach or a friend that you'd like to share with others? I think probably the biggest piece of advice that I got was to believe in yourself. When you go through a program, you're going to be overwhelmed. And it's even when you graduate and you go from one specialty to another. You might have been an expert in one specialty, and then you enter another, you're at the novice level again. And it's like, did I make the right choice? But you have to believe in yourself if it's something that you really want. So it's not just your head, it's your heart. You need to believe in yourself. That's awesome. Believe in yourself. Well, thanks for that. Well, Dr. GW, thanks so much for your time. Always great to chat with you. And thank you to all of you for joining me on today's College Bound Success, College to Career. If you found today's episode helpful, be sure to follow, rate, share it with someone who's navigating their own college and career journey. For more tips, tools, and support, please visit my website at mostalskicoaching.com. I'll put that in the show notes as well. So until next time, stay curious, stay confident, and stay boundless. Thanks, everybody.